Welcome to today's video, where we'll be exploring nephronophthisis, a rare genetic kidney disease primarily affecting children and young adults. We'll delve into its causes, how it affects the kidneys, the symptoms to look out for, and the current treatment options available. Join us as we unravel the complexities of this challenging condition. Nephronophthisis is primarily caused by genetic mutations. These mutations affect genes responsible for the structure and function of the cilia found in kidney cells. Cilia are tiny, hair-like structures that play a critical role in sensing fluid flow and transmitting signals within the kidney. Over 20 genes have been identified that can cause nephronophthisis when mutated, including NPHP1-INVS and EK8. Inheritance is typically autosomal recessive, meaning an individual must inherit 2 copies of the mutated gene, one from each parent, to develop the disease. However, autosomal dominant forms exist, though they are less common. These mutations disrupt the normal development and function of the kidneys, ultimately leading to progressive kidney damage. The pathophysiology of nephronophthisis centers around the impact of dysfunctional cilia. When cilia are impaired, the kidney tubules, particularly in the corticomedullary region, undergo significant structural changes. These changes include cyst formation, tubular basement membrane disruption, and interstitial fibrosis. The cysts are small and typically located at the junction between the cortex and medulla. These structural abnormalities gradually impair the kidney's ability to concentrate urine, leading to polyuria, or excessive urination, and polydipsia, or excessive thirst. As the disease progresses, fibrosis and inflammation further damage the nephrons, the functional units of the kidney, eventually leading to end-stage renal disease or kidney failure. Nephronophthisis is considered a rare disease. Its exact prevalence is difficult to determine due to underdiagnosis and variability in clinical presentation. Estimates suggest that it accounts for a significant percentage of cases of chronic kidney disease in children and adolescents, potentially up to 15%. The incidence varies among different populations and is likely influenced by genetic factors and founder effects within certain communities. It's important to note that due to its genetic nature, nephronophthisis often affects multiple siblings within a family. The signs and symptoms of nephronophthisis can be subtle initially, often making early diagnosis challenging. Common early symptoms include polyuria or frequent urination, particularly at night, and polydipsia or excessive thirst. Children may also exhibit fatigue, failure to thrive, or delayed growth. As the disease progresses, individuals may develop symptoms of chronic kidney disease, such as anemia, high blood pressure, and electrolyte imbalances. In some cases, nephronophthisis is associated with external manifestations affecting other organs. These may include retinal degeneration, leading to vision problems, skeletal abnormalities, and liver fibrosis. The presence of these external features can suggest specific subtypes of nephronophthisis. Diagnosing nephronophthisis involves a combination of clinical evaluation, laboratory tests, and genetic testing. Initial suspicion often arises from the presence of polyuria, polydipsia, and a family history of kidney disease. Laboratory tests may reveal decreased urine concentrating ability, anemia, and elevated creatinine and blood urea nitrogen (BUN) levels, indicating impaired kidney function. Renal ultrasound may show small or normal-sized kidneys, often with increased echogenicity. However, these findings can be subtle and may not be present in early stages. The definitive diagnosis is usually established through genetic testing, which can identify mutations in one of the known nephronophthisis-associated genes. Kidney biopsy can also be performed, revealing characteristic features like tubular basement membrane abnormalities and cyst formation, although this is less commonly used due to the availability of genetic testing. Nephronophthisis can be classified into different types based on the age of onset and the specific gene involved. Infantile nephronophthisis typically presents within the first few months of life and is often caused by mutations in the NPHP2-INVS gene. Juvenile nephronophthisis, the most common form, usually manifests between ages 1 and 15 and is often associated with mutations in the NPHP1 gene. Adolescent nephronophthisis presents later in adolescence or early adulthood. The specific genetic mutation and the presence of external manifestations can further define subtypes of nephronophthisis. Understanding the specific type can help guide prognosis and management strategies. Currently, there is no cure for nephronophthisis. Treatment focuses on managing the symptoms and slowing the progression of kidney disease. This includes interventions to address polyuria and polydipsia, such as maintaining adequate hydration and potentially using medications to reduce urine output. Managing anemia with erythropoietin-stimulating agents and controlling blood pressure with antihypertensive medications are also crucial. As kidney function declines, dietary modifications, such as restricting protein and phosphorus intake, may be necessary. Ultimately, Most individuals with nephronophthisis will require renal replacement therapy, including dialysis or kidney transplantation. Kidney transplantation is often the preferred option, providing improved quality of life and long-term survival. Post-transplant, immunosuppressive medications are necessary to prevent rejection of the transplanted kidney. As nephronophthisis is a genetic disease, primary prevention isn't possible in the traditional sense. However, genetic counseling and carrier testing are vital for families with a history of the condition. This helps prospective parents understand their risk of having a child with nephronophthisis and make informed decisions about family planning. Prenatal diagnosis is also an option for couples at risk. Early diagnosis and management can help slow the progression of the disease and improve the individual's overall well-being. The prognosis for individuals with nephronophthisis varies depending on the specific type and the age of onset. Generally, the disease progresses to end-stage renal disease or kidney failure within a few years of diagnosis. However, with appropriate management and renal replacement therapy, including dialysis and kidney transplantation, individuals can live longer and maintain a reasonable quality of life. Recent research is focused on understanding the underlying mechanisms of nephronophthisis and developing targeted therapies to slow disease progression. This includes exploring potential treatments that address the underlying genetic defects or target the inflammatory and fibrotic processes that contribute to kidney damage. Gene therapy and other novel approaches hold promise for future treatments. Furthermore, efforts are underway to improve early detection and diagnosis, allowing for earlier intervention and potentially better outcomes.